for the vast majority of conditions and the majority of patients, access to our notes and our information is limited and restricted to the people who are directly involved with our care.
So it'll be the doctors, the nurses, the receptionists, the administrative staff, the people that you interact with, but also the people that you might not interact with that work behind the scenes in the laboratories and the like, that all need access to identifiable data in order to provide safe and effective care to you.
The issue at the moment is because other people may not be able to access that so easily, they can't identify whether you might be able to take part in research. And so a lot depends on whether the GP is working with you, is research savvy, would like to put you forward in a trial.
The problem we have is that if the NHS is to become this hotbed of research for patient benefit in the future, we will have to allow access to notes and information for researchers whose interest is not the patient being treated at the moment in terms of their care, but it is the care and the treatment of patients in the future down the line. And I think the best way to improve recruitment to clinical trials is simply to offer them to more people. The challenge with this is it means you'll have to identify the patients from their data and from their records before you actually make the approach to them, which means that a researcher who is not involved with their care or their treatment is going to find out who they are.
When you are diagnosed with a condition that is coded, so depression has a code, a cold has a code, everything has a code, but there are also free text notes. This is why the doctor diagnosed you with that. What is the context in which they made that diagnosis, and why did they think that that was the appropriate diagnosis? And while codes are sensitive, the notes are even more sensitive.
The key to me about access to patient records, and particularly to my records, is what is it being used for rather than who's using it. So is it going to be used by somebody to start selling me things I don't want? Are they going to take account of some aspects of my life that might count against me in future, such as when I'm going for a job interview? There is that question of how far does that information go? Who's got it, and then who are they giving it to in turn? I would argue that access for medical research, which is going to benefit other patients even if it doesn't benefit me, has to be a good endpoint.
In order for people to feel comfortable that others can have access to their medical records, they need to know there's a safe way of doing it, it's secure, that they've been able to opt out or object if necessary, and that it's managed very carefully, and that there will be repercussions if someone or an organisation breaks that.
Under the common law, a healthcare professional that receives identifiable information that relates to an individual's care or treatment has to hold that information in confidence. And in previous cases, the courts have said that one of the important things to consider is whether or not a use of information falls outside a patient's reasonable expectations of privacy. At the moment, we can assume that a patient is going to expect their information to be held confidentially and to be used for the purposes of providing their care and treatment. One of the questions is, under what conditions might a patient reasonably expect their data to be used for other purposes as well? What we're interested in hearing from you is what currently falls within your reasonable expectations. Do you currently expect research use of your data? Do you expect the data to be disclosed outside of the direct clinical care team? Do you expect it to be used for research purposes? Would you need to be provided with particular information? If so, what information would you need to be provided? By whom, when, and how would you expect to get that information before you consider that to be an appropriate use of your data?